Thank you everyone for coming today. It's really great to see some new names and some names that came last week as well, so thank you very much. As you know, or as you may not know, I'm Rhiannon Oakley, and I'm the co-founder of Oakley Coach, and my wife and I are both coaching, what's the word? Qualified coaches, and Philippa Oakley obviously is a chiropractor, and we've invited Chris Chippendale to join us today on this webinar, and he is also a chiropractor, and he
does patient-centered training. He runs patient-centred training.
That's the one.
Can I just jump in? Can everybody in the chat just say if you can hear us okay? If we can just get some thumbs up in the chat. Yeah, good.
Great,
okay,
thank you.
Fabulous,
thank you.
good, just checking. So.
Right, so if you could screen share.
Yeah, brilliant. So I'm just going to share with you a little talk that we've prepared. So
great. Oh, we've got Chris up there.
That's okay. Ignore Chris. He's cool.
So Oars, it's not a boat. So it stands for
open-ended questions, affirmation, reflections, and summarising, and it's a key skill of motivational interviewing.
It's a really great tool for improving your questioning and listening skills, which is obviously vital in with your patients in a clinical setting. So many of you already know these skills and already use them as well. We're talking today about how to use them and examples and stories of how we've used them ourselves. And it's just a really great opportunity at the moment to talk about these listening and communication and softer skills, basically, because you've got an unwitting audience and your family members who are stuck with you in your house at the moment, so you can practice some of these skills with them, or even your colleagues that you may meet on this webinar today. So first of all, the plan of attack is that Chris is going to take over O and R for you, and myself and Philippa are going to take over A and S. So that's obviously not in order, but it's not a tool that you have to do in order, if that makes sense. And then we're going to have questions at the end. So first of all, I'm going to pass on to Chris, who is going to share his screen with you, and then we can get going with that. And if you could try and leave your questions to the end, that would be great. Thank you very much. Over to you.
You got my screen?
Yeah, got it. Perfect. Oars.
Cool. All right, lovely. So yeah, we've got the 4 oars here. Just before we start, I just want to make mention, this is a presentation I've used before. We'll make the slides available for you afterwards. You'll see why in a minute. We're going to skip around and not do them all in order. But you can, if you want to go back, I'll give you the link for this. You can look at this later. There's a bit I've got on here for the A and the S as well, although Philippa and Rhiannon are going to do that. There's some video examples in here. I'm not going to show those now just for time, but you can go back and you can view those later. There's some exercises you can do. A couple you can do on your own, some you can do in a group. Like I said, get a couple of colleagues together, get a group call going. You can practice some of these as well. We're really just going to go over to give you an idea of what these skills look like. The practice is really key. These aren't the kind of things that you can just take and straight away go, oh, I've got that and I can do that really well. The more you practice it, the more familiar you become, the more effective they are. And like Rhiannon was saying, now's the perfect opportunity to practice this with family. All the skills here, they're not patient specific. They're not ones that you can only do with a real patient. These work for conversations with pretty much anybody. I often say when I cover this in seminars that really you want to practice this at home so that when you do it with a patient, you're already familiar with it. If you practice it the first time ever with a patient, it's not going to be that great, it's not going to be that polished, it's going to feel a bit awkward, and it's going to affect the therapeutic alliance that way. So, and also they can just help improve your relationships with other people. My marriage has got better through using these skills. It makes you a better listener. People can understand that you're trying to connect and empathize better. So don't look at this as this is to help you with your patients. These are general communication skills that you can use pretty much anywhere in life. So we're going to start. The O stands for open-ended questions. Now, there's a couple of videos we shared in the group earlier this week, just going through the basic concept here. So an open question, it's different to a closed question. Closed ones, essentially you've limited the answer in some way. It doesn't have to be yes or no. It could be there's only like a multiple choice answer. Stephen Rolnick, who's one of the originators of MI, I really like the way he defines it. He says an open question is one where the answer has the potential to surprise either you or the person you're listening to. I think that's a really good way to look at it. If it's a closed question, there's no potential for surprise. And sometimes when you're talking to somebody, they might give an answer that surprises them as well. So that's a nice way to know if your question's open or not. Does it have that potential? And the nice thing with open questions is they give you the wider picture. They're quite good for getting an overall view of something. Closed questions are good for getting specific detail. And they both have their place. You know, it's important to say here, I'm not trying to tell you that all your questions should be open and that closed questions are bad or inferior. They're not. They're just different. And you just want to make sure that you're thinking about when you're using one or the other to really enhance that conversation. So open questions, they give you the wider picture. I generally recommend starting with more open questions in the consult or in the conversation. And then later on, you can bring in more closed questions to get up the specifics. We want to get an overview, first of all, get the big picture, and then we know these are the areas where we might want to drill down and get more detail, maybe with some more closed questions. If we just start with closed too early, we run the risk of just limiting it straight away. And sometimes we'll miss there's a whole other section that we didn't get the information on. And it allows people to explore their own thoughts, particularly if you're talking about the impact that somebody's problem's having on their life. Maybe they haven't thought about that consciously. So it allows them to kind of explore that. And often there's almost like a process of realization. If you ask open questions and get into some of this, people start to really explore their own thoughts a bit. So I'll just go through this quickly. Most of you have probably heard the metaphor before of the blind men feeling the elephant. You know, one gets the trunk and thinks it's a snake, one gets the leg and they think it's a tree. Open questions are basically allowing you to step back and making sure you're seeing the whole elephant and getting that big picture. They're also really good for just empathizing better with people. When you're asking open questions, it just gives this idea that you're more interested in the other person as a human being. You're interested in their experience. You're not just looking at them as a problem to solve, or their issue as a problem to solve. If you drill in with lots of closed questions and get very analytical straight away, sometimes it can come across like you're less interested in their experience. So it's good for just showing you've got that respect and oh, don't know where we've gone there. Yeah, so just demonstrating respect and empathy, and it just balances out that power hierarchy a little bit. A lot of people in clinical practice are going to come to you and they're going to feel like you've got this power authority. You're the more dominant one there, just because you're the expert with the expert knowledge. And while that's true to a degree, open questions just help to just even that out a little bit. It just sees that. So, like we just covered, it reduces that power hierarchy as well. The thing you'll also find, if you ask a few open questions, you'll probably get answers to several follow-up questions already. So in the clinical context, if these are your standard history questions, your OPQ or ST questions, ask a few open questions, you might get most of those answered already. So you find that you have less closed questions to go back to later as well. But like we said, there are advantages to closed questions as well. I don't want to just write those off and say they're not important. They can, if you're too reliant on them, make the patient self-censor. There's some great research out there showing that the average patient is interrupted by their GP about 17 to 24 seconds in. So most people get less than half a minute to explain what's going on before they're interrupted, usually with a closed question. And what this does, whether you interrupt or not, but if you just drill in with closed questions, it can give the impression that maybe you don't have as much time, you're in a bit of a rush, you want to get straight to the point. And patients will sometimes pick up on that and then decide to leave bits out. They'll self-censor and they'll go, oh, well, I won't tell them that, that's not relevant. And we've all probably realized that patients do this sometimes anyway, and they're not qualified to make that decision. If they're self-censoring, they might be leaving out really important information. One of the studies that actually looked at GPs who interrupt found that GPs who interrupted generally missed about 25% of what they considered the key clinical info. So this is, although that was more interrupting, this applies to closed questions as well. We've probably all had patients where 2 or 3 visits in, they've mentioned something that's really important. We really wish we'd known at the start. And often that comes because they've had this experience with other clinicians before. And even if you are warm and empathetic and take the time, they're still thinking, oh, I'd better get quick to the point. Doctors don't have a lot of time. But they are still important. Your red flag questions, ruling out red flags, these have to be closed. And you might get some of this information through open questions, but ultimately, these things, we need to make sure we've got clear, specific answers. Have they had bowel or bladder function disturbances? Yes or no? We need to make some of these closed. So don't think they're not important. Things like this, they're really key. But like I said, I would normally start more open and then come to these a bit later on, once we've got that rapport and momentum going. And they exist on a spectrum as well. So like I've mentioned in the video the other day, it's not just are they yes or no questions. That would be at the extreme end of closed questions. You could offer somebody multiple choice. You might say, is it better morning, afternoon, or evening? Now there's 3 options. It's a bit less closed. Or you could be asking about a specific type of answers. So what date did it start? How long have you had this? There's not really potential surprise there still, because they have to answer in a certain type of way. So it's not all either yes, no questions and then everything else is open. There's this spectrum to them there as well. And like I've said, you might shift that balance during the conversation. Sometimes it'll ebb and flow. You might ask some open questions. You're talking about one specific issue. Maybe you'll then drill into some more closed ones, get a few specifics, and then maybe you'll open it back up again. And you'll start to look at a few other areas and go back to open. So you may get this ebb and flow with it. Generally, in my practice, I find that it's a bit like a funnel. I'll start open and gradually come down into the closed ones at the end. And this, if you haven't seen the video in the group, go into the group afterwards. We'll send the link around. We talk about this already. One great way to do this is if you, instead of asking, does this do X, Y, Z, like, does this affect you being able to exercise? Does this affect you when you're at work? Change that to how does. That makes it a more open question. It's not a yes or no answer. And often you'll get people who might have said, no, it doesn't. But when you say how does, they sit back and think, and they might go, well, not really, but it does bother me actually sometimes when I'm warming up, it's more sore or something like that. So that's one way you can open the questions up there. There's some examples I've put on here. We won't go through them all now. Just a few different questions you might ask, and you can have a look and see whether you think they're closed or open. Okay, so that's just giving you a brief overview of the open questions there. Philippa and Rhiannon, did you have anything you wanted to add in on that section?
No, I think you've covered it all quite comprehensively. I mean, certainly with open and closed questions, they always come into play, as you've said, in clinic with our patients. And I think it's important to emphasize. Sorry, I keep getting empathise and emphasise the wrong way around today. It's important to emphasise that actually these are all skills, all of these motivational interview skills and the Oars skills are stuff that a lot of us are already using already. So it's just knowing how to apply them and also raising your awareness, which is a lot of what coaching is. It's just raising your awareness of when you might be slipping into closed questions without necessarily being aware of it. So
bringing your own things as a clinician to your patient. So open questions is more about being open to what your patient wants to talk about rather than what you want to talk about.
Yeah, absolutely. So yeah.
Cool. Yeah, definitely. I know, definitely for me, closed questions, they're a crutch I fall back to if I'm not sure what to ask, or I get a bit caught up thinking analytically instead of being present. I can tend to just go, okay, ask some closed questions to give you time to think, which isn't always necessarily a bad thing, but it's like you said, being conscious. If you're aware that that's something you do, then you're more likely to be able to stop and think back and make a better choice with it.
Yeah. And don't beat yourself up either.
Yeah. This is not a webinar on how to be the perfect communicator.
No, absolutely not. No, it has to be human.
If anyone's seen that one, let me know. I'd love to see that. So we're going to skip ahead. This will make a bit more sense in a moment. We're going to go to R now, which is reflective listening. Reflective listening, this is probably, if I had a favourite Oars skill, it would be this. This is one I really enjoy using. Essentially, this is proving to somebody that you've listened. Because you could be the best listener in the world. You could ask all these brilliant open questions. You could be really present, really actively listening, taking it all in. But if you don't somehow convey that back to the patient, then how do they know you've really been paying attention? And obviously there's things like your body language will give that away, eye contact, these are all important things as well. But reflective listening is a really good way to prove to somebody not only that you've listened, but that you've understood. So basically, reflective listening is listening with occasional what we call reflections, which is where you just offer something back that you've heard. You just reflect back what you've heard to that person. And it doesn't mean it's every single thing that they say, but just occasionally you'll say something back to them and people will then go, oh yeah, that is what I said. Good, Chris has been listening. You know, they've been paying attention. And again, it's good for just building that empathy, making sure you've understood things properly as well. Because sometimes you can get misunderstandings creep in. Anyone in a long-term relationship knows this. You said one thing, the other person's then reacted differently or unexpectedly, and it turns out that the words you used maybe weren't quite the same thing to them as they were to you. So it's a good way to just make sure that you're already understanding this person. You're kind of constantly checking back in that you're both on the same path with it. And it's good for building momentum as well. So if you've got somebody who's a bit like type A, quite sharp, you know, the kind of people you think don't really want to be here, or they're not particularly verbal, they tend to give one-word answers, then reflective listening can actually help to get that momentum going. It's a little bit like a bit of a rally in tennis. You're just warming up, going back and forth with each other as well. Or for people who are quite anxious, if they're nervous, if they're shy, if they're a bit concerned, then it's a good way to help them relax a little bit as well, more than just question, answer, question, answer. And when you get comfortable with these as well, this can seem, people often get a little stuck at the start, I think, if they try and do this straight away. So I wouldn't lean into this hard now, but when you get more comfortable with reflections, when you get used to it, you can use them to direct the conversation. A lot of criticism, you know, MI gets and communication approaches get is that people often go, oh, I don't have time to, I can't let patients talk for 30, 40 minutes. You know, they'll want to talk all day. I haven't got time for that. I've got to get on and I've got an exam to do and other people to see. Because they think that using this is just about talking and listening all the time. But when you get more comfortable, you can choose what you're going to reflect back to that person. And you can use that to steer the conversation. So they might have mentioned something about a knee issue they've had. And if you reflect that back, then they'll go and give you more information. So you can use it kind of to pick and choose. When I first learned about this, the metaphor I had is it's a bit like you're a guide for mountain climbing. And you're taking people out who want to climb this mountain. And a good guide isn't telling them this is the way to go. And it's not trying to make them go certain routes, but they'll see which way that person wants to go. But along the way, they'll point out, oh, there's another route up here that could go this way, or they might show them there's a view over there. And that's kind of what you're doing with reflecting. Is you're just guiding that person, and they're still in charge. You're not taking power over them, but you're just being a bit selective with how you can direct it to get the information you want as well. So how do we do this? Essentially, you're going to repeat back what you've heard. So you're going to say, patient says, you know, oh, I've got this really sharp stabbing pain in my neck. And you essentially repeat it back to them. But the key thing is you do it as a statement. You don't do it as a question. So I reflect back, oh, you've got a sharp stabbing pain in your neck. I'm not going to go, oh, you've got a sharp stabbing pain in your neck. It's exactly the same words, but the inflection's key. So you go down at the end of the sentence. You don't go up as if it's a question. And that's quite important because questions can sometimes seem a little bit challenging, a little bit threatening. You know, if you've got somebody who's talking to you and they're saying, oh, I know I should exercise, but I don't really have the time. I could reflect back, you're struggling to find the time to exercise. And that would seem like I understand. But if I went, oh, you're struggling to find the time to exercise? That little question, it can seem a bit challenging. They might interpret that as a criticism. They might feel a little bit of judgment, even if I didn't mean that at all. Also, it's rather annoying if you're talking to somebody and they keep questioning what you said over and over. So saying it back as a statement is quite an important part. We'll get into that a little bit more later on, but making sure you're doing that, it can seem a bit uncomfortable at the start, but it really helps get that momentum going. And also, you want to make sure There's a bit of a balancing act here. If you always use exactly the same words in your reflections that the person used, then it shows you've heard the words they've said. It doesn't really show so much understanding. So you want to be a bit careful with that. When we really understand somebody, we can put their experience in our own words. So if you reflect the same thing back, phrase slightly differently, but meaning the same thing, then it really shows you've understood it. So you want to make sure you're not just copying the person over. Having said that, personally, I always use the same descriptive words for their symptoms or their problem, or any metaphors they've used. If they said it's like a knife in there, I'm going to say it's like a knife in there. Because those ones, it's a very individual thing a lot of the time, how they describe their symptoms. And if I get that, I might use two words that feel the same to me, but if they don't to that patient, they're going to think I didn't understand. Just to give you a really quick example with that, I always thought of like shooting, stabbing, and sharp pain as the same thing. In my experience, I would use those words interchangeably. But I had a patient a few years ago as a police officer, and he said, "Oh, I've got this really sharp pain in my side. Whenever I turn, it's really sharp." And he actually he said, "It's not a stabbing pain. People think being stabbed is really sharp, but it's not. When somebody stabs you, it's like being punched." And he actually had experience of that in the line of his job. So went to show that if I'd said, "Oh, that stabbing pain you've got there," he would have gone, no, it's a sharp pain, it's not a stabbing pain. And although I thought I'd have communicated well, he would have felt like they didn't really understand it. So terrible and horrible is another example. Those are words that are, to me, they're awful, terrible, horrible. They're all meaning the same thing, but they don't necessarily to the patient. So I would generally recommend, this isn't a rule, but for that bit, you're probably better off using the same words and phrases just for their symptoms there. And like we've said, it's a bit less threatening than questions. I really like this diagram. This just kind of encapsulates the whole process of reflecting really nicely. So in this example, I'm the patient and then you would be the clinician. So first of all, I'm feeling something and I'm thinking something, and I have to convert that into words. So I take my thoughts and feelings, I put them into words, and then I say those words to you. And I translate those words into sound vibrations. That goes across, that then goes into your ear. Your ear translates those vibrations back into neurological signals, and then your brain interprets those words. And then you interpret those words as what you think I mean, so your interpretation of my thoughts and feelings. And all along the way, there's a lot of places where that could go wrong. There's a lot of potential for mistranslation, miscommunication. So when you say it back to me, you're essentially coming back and just closing that loop, and you're checking that what you've understood and what you think I mean is the same as what I tried to communicate. So by closing that loop just by offering reflections, you're constantly checking back that you're both on the same page there. And sometimes it can be really useful for me as the patient. If somebody reflects it back to me, I might go, actually, no, now I think about it, I wouldn't put it that way, or that's not quite what I meant. And I actually realized that the way I said it maybe wasn't the most effective way. So it helps people kind of clarify their own thoughts, and open questions will explore that, but reflecting can help to clarify it sometimes as well. Like I said, this takes practice. It sounds a bit strange and artificial now, but as you give this a go after this webinar with other people, you'll find quite quickly as you practice it, you get more comfortable with it. So there's some exercises there you can do, and there's a few statements where you can practice what you might reflect back to those particular statements. So those are kind of simple reflections. Simple reflections are just kind of showing back to check you've understood. So there's not a lot of interpretation in there. And it's quite good for just demonstrating understanding, particularly at the start of a consultation or a conversation, and good for getting that rapport going as well. Complex reflections, though, these are ones where there's a little bit of guesswork involved. They're a little bit more complicated. They can take a bit more practice. I usually use them further on into a conversation once I've got a bit more information. And they're better for showing that you've really understood this person. You can really empathize with them. Like I said, they tend to involve a bit of guesswork. This is where people sometimes get a bit nervous at the start. They're worried about guessing incorrectly. They're worried about getting it wrong. In my experience, and pretty much everyone I've spoken to who does this, that if you're genuinely trying to connect with somebody and you're generally trying to understand, you have that curious mind, patients will feel that, the people you're speaking to will feel that, and they'll forgive you pretty much any misunderstanding. People know that that happens, and if they know that your heart's in the right place, they're not going to mind if you get it wrong. And that's the lovely thing with the reflections. You can check it back and they can correct you, and you both know that you're on the right page. And so there's 3 types we can break this down into. The first one is continuing the paragraph. And this is basically where you reflect back what somebody said, but then you add on what you think the next sentence might be. It's as if they've given you part of a paragraph and you're going to fill in what the next sentence might be. So it's a little bit of guesswork. So you might have somebody who's feeling very frustrated because they can't go back to the gym, and they say, well, this pain keeps stopping me from exercising, and you know, I started going 6 months ago and I've lost a bunch of weight. It's really frustrating. And you might reflect that back and go, it's frustrating because you lost that weight and you're worried that you're going to put it back on again. They haven't told you that, but you've sort of understood that, and you can reflect that back to them. So that would be a simple version of that, just adding in a little bit extra. You've also got what are called double-sided reflections. These are great when you're having a conversation with somebody and there's some level of ambivalence there. Like there's a bit, they've got 2 conflicting reasons for doing something. So they might say, you know, oh, I know I should exercise, I know I should do the exercises my last clinician gave me, but you know, I really don't have the time. And you could reflect that back and say, so you do really want to do these exercises, but you don't have the time. The problem with using but to join those is that it sort of implies a bit of a value hierarchy. So if I say you really want to do it, but you can't find the time, it kind of negates that first part. So in that case, I'd probably be reinforcing you don't have the time to do this. Whereas if you change the but to and just changing that one word, suddenly it offers them back as 2 equal problems. So you can say you really want to exercise and you're really struggling to find the time. And I haven't put a value judgment on those. So you can take what somebody said earlier as well and add that on to something else. They might have talked earlier about how, you know, they really want to be getting into exercise, they really want to do this, and then later on they've said they're worried about how it fits into their lifestyle. So you can take something from previously and offer it back. If you get a sense that there's some ambivalence there, there's some tension between what they might want to do and what they can do. And then there's reframing, which is most of us, I think a lot of us actually do this quite a lot without maybe being so conscious of it. Reframing is basically where you reflect back what they've said, but then you put a different spin on it. So you might put a positive or a negative spin. So one example, I often do this with people is maybe they've been doing well and they've had the odd flare up, but they're doing better and they're spacing out. And it's been 2 weeks since I've seen them. And I go, yeah, how have you been? They go, well, you know, it was good for the first like 10 days, but then after 10 days it flared up again. It's been bad since then. And I might reframe that as going, okay, so this time it was 10 days before the pain came back. You know, you lasted 10 days without treatment before it flared up. So I'm reflecting back the same information, but I'm putting that spin on it to show them, hey, maybe this isn't as bad as you think. Maybe there's a positive side to it. Maybe highlighting a strength. So that's something that you can do, and you probably already, I think a lot of us do this quite easily. But again, it's just like being a bit more conscious with it. There's some video examples here I'm not going to go through now. This was a patient, Jordan, is a real patient who very kindly agreed to let me film his initial consult and his report findings. So we've got a couple of clips of him going through here as well. You can watch these later on. All I would say is I haven't put these in there to say these are perfect examples. They're not. It's just the only examples I have with a real patient. So I'm not saying this is exactly how you should do it, but hopefully it gives you an idea of some of the skills we're talking about. So there's a couple of clips of him now, so we'll skip through those now. And there's a couple more exercises after that too. This is all on a web browser, by the way, so don't worry that you've got to install different software for this. It's all a link that you can use at home. So last bit, just a couple of troubleshooting bits. This is where often people can get a little bit stuck with reflecting. The main one's turning it into a question. Like I said before, a reflection, the sentence goes down at the end, not going up. Often when people aren't quite sure, they may be nervous about getting it wrong or being misinterpreted, is they put it up at the end of the sentence because they're not quite sure. And again, that can seem a bit challenging sometimes. So really try and practice this of just keeping it as a statement, even if you're not sure you're right, because they will correct you and they will understand. And also hesitation, it kind of has the same effect here. particularly if you're trying out a new complex reflection that you haven't used before. Often you can hesitate because you're a bit unsure and there's a bit of guesswork and you think maybe I haven't got this right. But that hesitation will kind of make you turn it into a question as well. The other thing, the last bit that can sometimes, it can feel like you're putting words in people's mouth. When you're reflecting back something a bit more complex, you can feel like you're telling them how they feel. But it really doesn't have that effect on the person. It shows you're trying to understand. And it will be quite clear to them that you're doing this for the right reasons. If that's really what your intention is, you're not going to be putting loads of words in somebody's mouth as you do it. But really, it just takes practice with that. So that's covered it there. There's a couple of resources in that you can look at them later on. Rhiannon and Philippa, have you guys got anything else you'd add for reflective listening?
You wrote something very interesting as a note.
What did I write?
So you were talking about the word but, and we call it something quite funny actually. We call it a butt flag. I think I learned that from an NLP instructor actually, which is something else that I'm trained in. And it's as you say, it's something that it's quite a negative experience when you say but to someone.
Like you did really well, but.
Yeah, and it's a little bit judgmental as well. So that's why you need to be careful with that word. It's another reason why we don't say or ask questions that start with why in coaching, as it's very judgmental and can get people to reply in sort of in a tone that they're just defensive and trying to defend their actions. So that's
And Amy, mouthful of tea for the butt flag. Sorry about that one.
Sorry, Amy.
And then if you're, it depends where you are in the world. But if you're anything like me, I tend to replace the word but with however, which is the posh version of but, which achieves the same thing. So if you say, you know, that was great, however, it's implying exactly the same thing. So it's another thing to be conscious of.
On the other hand,
on the other hand, so there's loads of examples of these kind of words that we kind of use and we throw into conversation, and it's really difficult to, I find I have to actively practice not to use the word but and to replace it with and instead, because as you said, and highlights the fact that they are both equal possibilities, and our patients often present with this this ambivalence. You have to raise their awareness of the fact that, you know, you smoke to alleviate your stress at work and you really want to quit. You know, they're both very separate real statements. Separate statements, but using the word and acknowledges both of them, and acknowledging people helps to validate people, and as we know, validation is really, really vital for them.
Alright, can you just add that question at the end when we've got Q&A? That would be great, thank you. So everyone now, whenever they say,
she's going to jump in over me. I was going to say something about reflection as well, because a lot of people asked, are you going to have a domestic on camera? A lot of people ask about using these things in clinic, and the research says that we should be using around 2 reflections for every 1 question that we ask, and that again takes practice. It's an interesting statistic because I think we naturally have a lot of questions that we need to answer, or we need to get the answers to, yet using reflections is a way of eliciting the same information from our patients without that feeling of interrogation. And we were talking in the chat just briefly about the fact that some statistics say that we should be talking around 50% of the time that we're talking to our patients, and that to me is a massive amount. You know, I would say that I'm silent for a vast majority of the time that I'm with patients, because we are less motivational if we are the ones hogging the stage. It's supposed to be all about our patients at the end of the day.
And it's eliciting that change.
I've just noticed Aidan Barry's on here, and I stole this line from him. He said, never miss a good opportunity to shut up.
Yeah, absolutely.
It's quite a good guideline.
You may not know that I actually trained I have a degree in journalism, and that training gave me the experience of actually a good journalist asks 1 question, and then the rest of the time, you will notice if you watch interviews now on the news, a good journalist will ask just 1 question and they will say nothing else. and the person speaking will literally just tell their whole life story.
Except at the moment, because there's lots of questions about coronavirus.
Yeah.
So it's not a good example. Brilliant. So thank you, Chris. So we're going to move on to the A and S side of things. I keep wanting to say the ass side of things and remind myself not to say that.
So we've got butt flags and ass.
Butt flags and ass. So can everybody see my screen? Hopefully you can. She says I'm just going to come out of the chat so you can. Yeah. So hopefully everybody can see this.
Thank you.
So affirmations, I think this is what most people think of when they think of affirmations, and you know, those lovely videos that are around of, you know, kids standing in front of the mirror and, you know, affirming, I love my life, I love my family. And affirmations, that's not what they are. Affirming people is all about expressing empathy, and it's important when we're talking about affirmations, Chris touched on this earlier, to talk about the difference between empathy and identity, because as practitioners we have to be careful about expressing empathy and not identifying with our patients. And this is something that I've talked at length with people such as our CBT therapists, for example. Anybody who has a history, for example, of anxiety or mental illness, as many people do, certainly many practitioners do. So I'm just muting people as I'm talking. There is a real difference between empathizing with somebody and identifying with them. And if we, press the wrong button, if we have a personal history of the same problem area, it can actually impact our ability to facilitate change in that patient. So for those people who have a history of anxiety, mental illness, even self-harm, if you're presented with that in a patient, it can actually impact how well you're able to elicit change and to facilitate change in your patient. So it's just something to be aware of. Now, with affirmations, affirmations are literally affirming your patient. It's literally what it says on the tin, and there are some ways to do it, because certainly when we were talking about this earlier, we said one of the big challenges that we find is that affirmations can come across as disingenuous, and I certainly think, being a bit British and a bit stiff upper lip, it's not always in our nature to give compliments and to give, you know, statements like that. Certainly, you know, if you tend to see, if somebody gives you a compliment walking down the street, you tend to go, where did that come from? You know, we have this natural thing of assuming,
needs to be genuine.
Yeah, it has to be genuine.
But that's also, just very quickly, there's a difference between compliment and affirming someone's.
Yeah, absolutely. Yeah. So it's not a compliment, and that's important to bear in mind. When you look online and look for examples of affirmations, I saw lots of them that started with, well, I think it sounds like you're a very positive person, or, you know, it seems to me like you've been going through a lot in your life or something. And that's kind of, it's a sneaky workaround, because yes, it is an affirmation, but a genuine affirmation should always start with you. So you are a very resilient person. It's as simple as that.
It's
to
fact,
give a genuine
rather than
affirmation.
a personal opinion.
Yeah, it's not about you. So you also have to consider the context, and this is where Chris talking about, you know, his complex reflections. The more that you know a patient, the easier it will be to put your affirmations into context. So these are some nice examples of ways that you can provide affirmations to your patients, and as you can see, they're not obsequious. They're not ingratiating or cloying in any way. They're just simple facts. So again, we'll make sure that you have access to all of these slides, so you've got all of these. And you can use these to provide evidence-based feedback. So one of the things that I tend to do is, if somebody is talking to me, I will say, well, based on what you've told me about your life so far, you're clearly a very resilient person. So they've already told me everything that they've been through in their past, and, you know, the things that they've struggled with to get to where they are today. And I'm using that to provide evidence-based feedback. And as we know, you can't argue with the evidence, although people do try. So the other thing to bear in mind is to acknowledge personal qualities and abilities. So these are always nice things. People always like to hear nice things about themselves. So this is another method of providing affirmations. Recognizing effort. So I was talking a little bit, we were talking about this in our talk last week, about recognizing effort and how we communicate with our teams. And this is something that, again, I think is often overlooked. practitioners often say that we don't get any real positive feedback, but also how often do we provide real, genuine, positive feedback to the people around us? And even something as simple as this statement, you know, just acknowledging that your patient has been putting in the effort, is a powerful statement, a powerful affirmation to make. And reframing, which again Chris has talked about, and this is something that you can use with patients who have had a setback. If somebody comes in with an acute flare-up, and I think Jonathan Field was talking about this last night, where he said about his patient who had hurt her back, and she said, but don't worry, I've spent all week in bed resting it. And that's not what we want, but also we don't want to jump in there straight away with the negativity. So we can say something like an affirmation of, your intention was good, you've been looking after your back, you know, that's great, even if it feels like you've had a minor setback this week. And notice that the temptation there would be to slip a butt flag in there, so you have to watch out for that one, because butt flags popping up all over the place. So I found this really, really interesting when I was looking around the research around this talk and things. And when it comes to affirmation and empathy, the two really go hand in hand. And you'll see on this list that I've highlighted a couple of things that were certainly quite surprising to me when I was looking through this, because some of these things on this list, this is a piece of research that's quite vintage now, but actually it still stands true to today. Some of these things are things that we consider part and parcel of what we do as clinicians, you know, giving advice, making suggestions, agreeing and approving, you know, reassuring our patients. How often do we say, you know, that it's completely normal? You know, we do these things, and they can actually be barriers to building rapport and creating that therapeutic relationship with our patients, because a lot of them are unsolicited, and they involve us placing our own interpretation on things. And reassurance, for example, is a lovely way of interrupting your patient's flow mid-talk. So it's something to definitely be aware of. And a big one at the bottom, humour. Humour is one that I find I use that an awful lot with my patients. I use humour, and it's something that can divert the topic of communication and distract patients and imply that that what they're saying is unimportant. So you have to rely on context. And the giving advice thing is an interesting one to think about. I had a patient a couple of weeks ago who came in, intense shoulder pain, guarding the whole thing, said, I've been working all week in this position so that I don't move my shoulder. And I did not have my brain switched on because coronavirus was happening. And I said, don't worry, I'll send you some resources about pain management and understanding pain, because it's really going to help you develop your understanding. The more that you understand pain, the better you're going to be able to control and cope with it. And she literally said, no, don't. And my big mistake there was that I had given unsolicited advice. So I wasn't building empathy with my patient. I wasn't building rapport with my patients. And what I should have done was quite literally say, would you mind if I give you some advice on this? Or would you mind if I tell you some of the things that I know?
Getting that permission.
Yeah, absolutely. So we refer to that as ask, tell, ask. So you can ask someone and say, do you mind if I tell you what I know about this? And then if they say yes, you tell them what you know about pain and understanding pain and blah, blah, blah. And then you can check in with them afterwards and say, so knowing what I've just told you now, how does that fit with what's going on? And you can also check in with them first and say, what do you know about back pain, or what do you know about headaches? Because you're implying that they have a certain level of knowledge already. And that's always nice to assume that our patients know more than we might think that they do. Mm-hmm. So these are some examples of statements to watch out for. I just realised that one's cut off on the page a little bit. So again, I'll sort this out before I send this over to you. In terms of affirmations and things to be careful of. I'm not going to go through all of this because you can all read. So we are going to move on to summarising now.
Yep.
So let me just get to my summarising. Sorry, I'm talking too much.
No, it's fine. We're just running.
Sorry,
a little bit.
No, it's fine. Time. No, we're fine. We've got time for questions at the end. So summarising is literally wrapping everything up in a bow and checking back in with your patient to make sure that you have the same level of understanding of the situation as they do. It gives the patient an opportunity to make any corrections, or, you know, as Chris said earlier, they can say, that's not quite what I meant. And sometimes when you hear it back, it means that you're better able to understand the situation that you're in when somebody is trying to explain your situation to you. So we use this in coaching quite a lot to help identify and promote this perception of discrepancy between what people say and what people want to do. For example, I've got a chap who desperately wanted to lose weight, and he was overweight and he was pre-diabetic, but he was drinking, I'm not joking, 30 grams of sugar in milk in lattes a day, and he could not understand why he wasn't losing weight. And once we raised his awareness of the fact that, you know, there was quite high sugar content in the milk and that might be where it was coming from, we could then lead into these questions and summarize the information that he'd been telling us. And we could use that to raise his awareness of that discrepancy by saying things like, I understand it's really important to you that you lose weight, and you're drinking a lot of milk still. So how does that fit with your goal? So,
and in the end, he changed it to oat milk. So
yeah,
that was a much better solution for him, and he chose to do that. He chose to make that change.
Yeah. So this is this is what would technically be termed a double-sided reflective listening summary noting a discrepancy. So that's an example of how you can use it in practice, and you can see how summaries tie in with reflective listening and tie in with sort of open-ended questions as well. So you can package these things up into a really nice technique that you can utilize in clinic. So it's not about using O skills in isolation, A skills in isolation. You can incorporate all of them into one neat question. Summarising can be done collective, linking, or transitional, and these are some different examples of how you can utilise these. I'm rattling through things because I'm just conscious of time. And there are some nice little coaching skills that you can tie into these as well. So when we're talking to people, we want to start eliciting change talk, and it can be helpful to start eliciting change talk during the summary. So for somebody, for example, who wants to stop smoking, who wants to stop smoking, but they use smoking as a coping strategy, as a stress release from work, some of the questions that we might want to ask would be to elicit change and to start talking about, okay, so if you were going to stop smoking, what would you be looking to do? And we start to elicit that talk about the things that they would start to action in order to facilitate that change. So our chap with the ridiculous quantities of milk that he was consuming, we said to him, well, I said to him, you know, you want to you tend to reach for less healthy snacking options as your stress levels at work increase. If you were looking to change this, how would you look to go about it? And another thing that we do in amongst that is then to rank it. So on a scale of 0 to 10, how important is it for you to make this change? And a brilliant thing, which is one of my favorite questions then, is to say, if they say, well, I'm at about a 4 out of 10, you know, I know that I need to make this change, but I don't feel ready. Check in with them and say, so why are you at a 4 and not at 0? Because a lot of people would check in and say, why are you at 4 and not at 10? And if you ask them that, they're going to start hitting you with all the negative reasons about why they're not at 10. You know, I'm still overweight, I have a penchant for eating Cadbury's dairy milk, and, you know, Easter is coming. And we can start to elaborate on the importance and the need and what makes it important to them. And these are all questions that will help to facilitate that conversation and that flow.
Very briefly, people may have noticed that Philippa just said a why question. Now that is an acceptable why question because it's more quizzical rather than judgmental, if that makes sense to everyone.
Yeah. So this is what I'm talking about with summarising can be used to elicit change talk. We don't want to elicit all the reasons why people aren't going to change. That's not going to be helpful. But certainly using that tool of, you know, on a scale of 0 to 10, how important is it to you to make this change? Why are you at that number and not at 0? It looks from the research, it seems from the research that it's important to do this because it accepts and validates that there are two sides to every argument. So for somebody who wants to stop smoking because, you know, they know it's bad for them and they use it as a coping strategy at work, you're acknowledging that those two things are in existence. So it's tying in with those butt flags we talked about earlier. And it also gives you some hints about action plans and implementing change going forwards, because you will then know for that patient, if they are going to lose their coping strategy that they rely on at work, so their 10-minute cigarette break, you know that an action plan going forwards needs to include some way of coping with stress at work that doesn't involve popping out for a cigarette. So you can then affirm the change talk as well. Sorry, I just accidentally stopped sharing my screen, but I was done already anyway. So that's basically everything that we needed to cover, and we've rattled through that to make sure that we got some time for questions at the end. And just a couple of other points that I would add, which I think are important, is, and Chris, feel free to jump in, and you as well, but when we're talking to people and when we're reflective listening, we don't have to agree with our patients. I think that's really important, because people think that reflective listening, the empathizing, summarising, reflecting, all of these things involve us giving our agreement. And there are ways to practice these skills without agreeing. For example, I'm never going to agree with a patient that smoking is good for them, but I can still acknowledge these things as fact. I can still validate that patient without causing that breach in rapport that can happen if you turn around and just go, well, no, smoking is terrible for you and really shouldn't be doing it. I don't know what you think about that, Chris.
Yeah, I think I often find people get in a bit of trouble with sort of empathizing generally, but affirmations are big things. That people think that empathy means you agree with the person, you agree with their choices, and it really doesn't. It's just about being able to see the world from that person's point of view. I think that's a Steve Rolnick one as well. Just about being able to do that and to demonstrate to somebody that you understand what it's like to be them. You don't have to agree with them. You don't have to feel exactly what they felt. You don't have to have the same life experiences. I think affirmations are a really powerful way to do that if you've used them carefully. And you guys, I think it was the workshop you did at BCA. You talk about putting the evidence first with affirmation. Is that right?
Yeah,
I really, that for me, actually, that's something I've started using. It definitely makes a big difference. I don't know if you want to talk about that, or if I should. Or,
yeah, so tell me what you learned.
Yes.
I'm going to get in trouble now. It turns out I got it wrong. So yeah, it was just the fact, if you're going to affirm something to somebody, you give the evidence for that affirmation first. So instead of saying, oh, you're a really caring person. You did that. You used that with somebody in the audience, and their first reaction was, "What do you want from me? This is a bit weird. You're trying to butter me up." Whereas if you say, "Oh, so even though you're in pain, you're really making sure that you're taking care of your family, you're putting their needs first, you're a really caring person." They can't really argue back with it then, and it makes it clear, oh, this is why you said that, especially when it's come from them, so they can't really deny it. But I really like that idea of saying, here's the evidence for what I'm going to say, and now here's the actual affirmation.
Yeah, I think it's really important with our patients as well, because it can help with this empathy, which we keep coming back to, putting ourselves in the place of where our patients are when they come to see us. Sorry, I just realised I'm touching my face. It's I
do that the whole time.
it's just can't help it. We were talking earlier about the fact that shame, for example, is known as the master emotion, and one of the primary elicitors of shame is unwanted identities. And I found that really interesting to think about the unwanted identities that our patients present with when they come to see us in clinic. So, for example, a big, strong, burly chap who's there looking after his family, and he goes out to work and he runs his business and things like that. If he's had to assume this unwanted identity of being a sick person or being someone who's unreliable, he's going to be in a position where he's possibly feeling a little bit of shame. And that is the master emotion. When you think about being in a situation where you might feel shame or you might feel embarrassment, that can be enough that it can put people off doing it. We were talking earlier about the fact that a lot of these webinars, we've got a lot of men who are stepping up to do it, and is there a reason why we don't have more women? And we thought, well, maybe there's something in that. There's a bit of imposter syndrome, or there's a bit of I'm not good enough, or there's a little bit of shame that ties into that. And it's just an interesting concept to think about where our patients might be, and therefore the importance of working on these skills. And it's something, when we think about us cancelling patients, if we fall ill and cancel patients, it literally involves, hell has to freeze over most of the time for me to cancel patients. And yet if a patient calls and cancels because they've got a cold or something, it's completely normal. It's seen as human in other people, and yet we don't see it in ourselves. And the way that we can help override those feelings of shame in our patients is with self-compassion and with empathy, and with putting in strategies to deal with anxiety and shame. And it really just highlights the importance of all of these skills, because they give us the capability to put ourselves in our patients' shoes, communicate with them in a way that speaks to them and to who they are, and doesn't place us, as you were saying right at the very start, in that position of I have power, I have authority. Because for me, an ego in healthcare is one of the most dangerous things that you can have. It's just an awful thing to have. And these are all skills that still give us, they allow us to use our knowledge and the skills that we have, but in a way that our patients will remember us, and our patients will feel that they've developed that relationship and they haven't felt ignored. And
they respect you actually as well. I mean, this whole situation with COVID-19, I'm not sure how everyone else felt, but there might be a little bit of shame about cancelling and closing the clinic, or even staying open.
Yeah.
There was a lot of shame spirals going on there. But yeah, really, really good point about looking after yourself as well as your patients. And I think that's a bit off topic, but anyway.
I was only going to add to that there was, I won't go into it now deeply, but there was a great paper I saw a little while ago. It was quite in-depth neuropsychology, but it was talking about how empathy is actually protective against burnout. And there's been a bit of flack lately. There's been a bit of a backlash against empathy, saying, oh, you'll burn out if you empathize, if you feel what they feel, if you take your patients home. But actually the definition of empathy that you've been talking about and we've been talking about is protective against burnout. It actually helps make sure that you don't do that. It's sort of, it almost like it increases your reserve for being able to be there for patients. So
filling your cup up first before you.
Yeah, exactly.
Yeah, I mean, that's the exact reason why I got into coaching, was because I recognized that we needed ways in which we could empower with our patients, as opposed to all of the burden being placed on us as practitioners. Because with these skills of us having the advice, giving the advice, patients not taking the advice, patients coming back in and saying, I'm not better, you're not doing your job, that's difficult. That's something I think pretty much every new graduate probably goes through.
Yeah, it's how you felt as a new grad, that you felt like a counsellor at the end of the day.
Yeah, absolutely.
And it's not your job to do that. And as caring professionals, you've got a job to do, so you've got to look after yourself and get that job done, as well as maybe signpost to other therapists that have the skills and knowledge to protect themselves, as well as to look after your patient.
And strategies to help your patients. I when I first graduated, I was working in a clinic that had an NHS AQP contract. And I remember one of the first ladies came in and I said, well, when did your neck pain start? Tell me what brought you here. And she said it started when my husband put my head through a brick wall. And, as a new graduate, it was like, well, how do I deal with that? And so these strategies, although they might seem like topics that come up time and time again, and, you can get almost inundated with people saying, you need to learn these skills, but you really, really do, because they're better for your patients. They're more structured, they're evidence-based, they're supported in the research, they're proven effective, and they've got exceptionally good levels of efficacy. They can promote positive change in our patients, but they also protect us as clinicians, and they provide structure, and they mean that we don't get so emotionally involved that we're facing overwhelm and burnout, as you said, Chris.
Yeah, I think that's it's a balancing act, because there's a lot of people who won't want to go into the psychosocial stuff because they're I don't want to be a therapist, it's a bit scary, I don't know what to do. but I think there is also a danger of going too far. I've definitely, personally, I've felt that before. There's been occasions where I've thought maybe I was going a bit too far in that direction. That might have been me stepping out my lane. And I imagine this is true for most of us. I think for any clinician, there's a large part of us, we want to fix people. We want to help, we want to fix their problems. And, you know, I've seen how sometimes just listening to somebody, letting them talk about their problem can be quite healing. So it's being aware there can sometimes be a bit of a pull in that direction. And I've had to sort of step back a couple of times and go, oh, there's part of me that wants to almost become this person's therapist. And I'm not qualified for that at all.
That's why it's so important to network in your local area with other therapists, to know who to signpost people to. And even a very simple question that coaches use is, how do you know that coaching is suitable for this topic, this goal? So that's how I get out of it.
Because actually sometimes, although we're taught to signpost, and it's a good thing to signpost, if you turn around to a patient and say, well, it sounds to me like speaking to a counsellor might be a good idea, that's unsolicited advice right there. That's not going to go down particularly well. So, you know, it's again thinking about how all of these skills apply to different aspects of the patient interaction and that therapeutic alliance. So well, I'm conscious of the time because we're 3 minutes over. Sorry, everybody, stolen 3 minutes more of your time. So we have, and I'm going to say this publicly in front of everybody, but Chris is going to post a resource. So he's now accountable to all 200 and something odd participants. Chris is going to produce a resource.
I did ask him to say that.
He has been warned that we were going to say that. Chris is going to post a resource later, just kind of summarising everything that we've been talking about here. I'm loving that everybody's watching out for butt flags now. This is brilliant.
Yeah, that's what you're going to think of every time.
And we will get the recording to you as well. Don't forget to join the group coaching. The coaching group, we'll send a link out to that as well, because there's lots of really nice positive chat going on in there, and some resources that we've produced as well. It does say for chiropractors, but obviously we're one happy family of manual therapists, all you lovely osteopaths who've joined us as well.
Physios,
please join, sports therapists
and
and everyone, because we're all in this together. Which always makes me want to sing High School Musical and then admit that I've watched High School Musical. So yeah,
you have a poster of it.
I did. I did many years ago. Carry on, Hannah. Stop laughing.
So glad I haven't broadcast on this webinar.
I think we had a couple of questions on the chat. I think Ulrich had one that we need to scroll back through, unless.
Oh yeah, about do you warn the patient whether, do you sort of pre-warn them or mention that you're going to be reflecting? Yeah, I personally, I don't prep the patient, I just do it. In my experience, it's never been something where I thought, oh, I should have mentioned that early on. It's more natural than you think it would be. When we talk about this stuff and ways of communicating and things to try and say, it always sounds a bit artificial. And it can end up feeling like, oh, okay, I'm going to try this thing, maybe I should warn them. But when you practice it, you find actually this is a pretty natural way of talking anyway. So I've never warned a patient that. I've never said I'm going to reflect things back to you. It's just something I've done, and it's just become part of that flow in that conversation. So I don't know if you two feel differently on that.
I think the more it's a conversation. I mean, I think that's the conversation that I have with a lot of practitioners, is how do I use these coaching skills in like a 15-minute, 20-minute session? And it's not a separate thing. It's part of the conversation that you're having with them. I mean, you might not be able to hear all of what they're saying because their face is in a bench, but it's just a natural process, and it's over time. So you're building that relationship, you're building that rapport, and you're building those skills alongside that conversation. I mean, something that I think that I'm going to add to the group is a lot about the listening out for learning preferences. So if people say feel, or
yeah, I feel like that's the way forward, or it sounds like that's the right path for me or something is listening to their learning style and their preferences
and reflecting that back at them to sort of build that rapport as well.
And that's absolutely it, Ulrich. If you prep people, then it feels like you've got an agenda. And you know, that's
not about that.
It's not about that. I think the only time that I don't check in with reflections, but I do check in with advice, as I've said. So I will say to the patient, you know, would it be okay if I told you a little bit about what I know? Or, you know, would you be interested in hearing some advice from me on this topic? So I would always check in with them before I offer advice, but I wouldn't necessarily check in before I offer a reflection, because hopefully a reflection will be done in such a way, once you've kind of mastered the art of it, be done in such a way that it would become part of the conversation. As we said, 2 reflections for every 1 question, so it's not a standalone thing, it's just part of that natural conversation that you're having with people.
And try it today. If you think it's going to be a bit weird or a bit awkward, just start slipping in reflections when you're talking to friends or family. Don't tell anyone you're going to do it. There's a good challenge I heard a while ago that I think is a good one to do, is try to offer 3 reflections in a row. Just so somebody's telling you about their day, give that a try. You don't have to tell anyone you're doing it, and you'll be surprised. You'll be thinking at the start, oh, how's this going to work? What should I reflect back? They're going to have no idea. It's just going to feel very natural. There's something Philippa mentioned in the last webinar that I think is really key as well. Is it's, to me, there's the way I break it down is I think these are strategies. These are ways you can go about a communication, a conversation. These are approaches you can take. Strategies, I think, are quite important. I don't recommend tactics. Tactics are where you're drilling into the specifics. So, sit with your body language like this, you know, take the pen out and put it on the desk, or those sorts of things where you deliberately mirror somebody's body language so they feel more relaxed. I don't really recommend those. I'm not saying that they don't make a difference, but if you're consciously doing that, it tends to feel quite scripted. And if the other person picks up on that, you've just killed the therapeutic alliance. It's really hard to come back.
I think the way that we phrased it was, if you're having to learn how to actively listen, you're not actively listening. You know, you should just be doing it. You know, if you're listening to someone, you don't need to sit there and, you know, be conscious of, my arms are unfolded, my legs are uncrossed, I'm maintaining eye contact. You know, you would just do it. It's just how we do it.
And if you practice the strategies, the tactics kind of take care of themselves. Really, you don't. It's not something I would generally recommend putting conscious effort in.
So, Jeff, sure, yes, the webinar will be available later. We will publicise it everywhere where possible. Somebody else, Kevin Kelly, asked and said, do we, if we've got a patient who's got a traumatic injury, would we approach the consultation in a specific way? Yes, I always would. So in our clinic, we use care response. So that helps us to stratify patients who are at low, medium or high risk of developing a chronic or a persistent pain problem. So we firstly use that because we know somebody who's high risk, for example, is going to need CBT-based interventions in order to get the best outcomes from care. And certainly all of those things that we've talked about in terms of being conscious of the statements that you can make that might be a barrier to creating empathy. And again, I'll make sure that you can read through all of those as well. Those are ones that sometimes I will even write down on my consult sheet beforehand, just to remind myself of stuff that I need to be aware of and stuff that I want to make sure that I stay away from. So yeah, I don't know about you, Chris, but I find if it's a major trauma or it's a chronic, a persistent pain problem, there's a very, very different, very specific way of approaching it. But that's partly because I love persistent pain. It's one of the things that I really enjoy in clinic.
Fully nerdy about.
Yeah, I get fully nerdy about. So that's probably like a whole other webinar, but yeah.
So we've had a question from Julia, if everyone's read that, resisting the temptation to tell patients the right answer. So I don't know if you've ever had patients, well, of course you've had patients before, who have never taken your advice. And then they come back in and then you give them the same advice again and again, they're not doing it. I think it's really difficult, and it's not bossy at all, because your practitioners, your experience, you've got the knowledge, you've got the skills, you want to be able to help these people, but they can't help themselves until they want to change.
This is something that we've talked about in our I think it was the talk we did at the BCO conference on empowering your patients. Because there is a massive temptation to just tell the patient the answer, and it can feel like you're kind of dancing around the topic a lot sometimes with coaching, and it's a massive problem is dealing with your frustrations of patients when you know the answer. But some of the questions that you can ask that can help get you back on that path and can help the patient get the answer themselves more quickly is saying things like, well, what do you think the options are? Or you love the whole, if time and money wasn't an issue, what would you be doing to resolve this issue?
You could wave a magic wand. All those
how would you
things.
fix this?
But that's more of a bigger topic, because after Oars, this is about questioning and listening. After Oars, then you need to actually have an action plan put in place. So that's a whole. But
Julia, if you jump in the group, because we've got we can talk about this literally all day, I'm sure, between all of us. And we can absolutely talk more about that as well. But no, you're definitely not alone.
No, you're not.
No, that's I'm quite bossy in that aspect as well. But I don't think it's the only thing I'd add to it is that I got this from Peter O'Sullivan. I saw him. He does a 3-day seminar where he actually takes patients he's never met and does a session with them on stage. And he's really, really, really good at this stuff. And he's really good at making them do all the heavy mental lifting. He makes them connect all the dots. He makes them work this stuff out. Because the thing is, if you just hand them the answer, if it doesn't completely fit with what they want to do, and it sounds like it doesn't, if they haven't followed your advice before, they won't attach any value to it and they'll disregard it. If they can get there themselves, it makes them realize, oh, okay, they've realised that themselves and they can take that on board. It's much more powerful, and that's going to induce longer-term behaviour change. But it takes patience, and I think just being willing to accept that you're not going to get everybody there. There are some people who are just never going to take that advice. They're never going to do the preventative work they should.
Because they're not ready.
Yeah, exactly. And the harder you push, the more likely you are to turn them off it. You're just attaching even more negative associations and connotations to that behaviour. So Lucy said that's how she approached their other half. I think that's quite true. Like I said, this isn't patient specific. This will help your marriage and stuff as well.
Yeah, exactly. I mean, certainly when we talk about empowering people, we used to talk about empowering our patients. We even did a whole seminar and a workshop on it, and actually we now talk about empowerment to and empowerment from and empowerment within, as rather than just
empowering
to empower someone, because it's this really nebulous construct. What does that even mean, to empower someone? And when we talk about power with or power to, we're either finding common ground with mutual interests to affect change, or if it's power to your patients, you're giving them agency, you're giving them the control back over the situation. And if it's power within our patients, it's recognizing their capabilities and their inner ability to affect change themselves. And again, it's taking the emphasis on us as practitioners giving to our patients, and more about us facilitating the stuff that our patients already possess. Because the amount of times I've said to patients, or used to say to patients, oh, you really need to stop smoking, and they're just like, whatever. If they're not ready to make those changes themselves, it's just gonna fall on deaf ears. And I've found, although this stuff might seem a bit clunky, and you might be thinking, well, how on earth, as Rhiannon said, how on earth can I fit this into a 15-minute conversation? It's actually stuff that gives you better relationships with your patients, better skills, better competencies, and a better work-life balance, for example, overall, instead of constantly working to be the one who's going to fix that patient, because we don't fix people, we help them fix themselves. So let your other half think it's his idea. You don't get this with women, you see. It just doesn't relationship. So
that's my favourite quote from Big Family Wedding is, the man's the head of the family, but the woman's the neck, and she'll turn the head any way she wants.
I'm not quite sure how that works with us, but there we go.
So it's obviously like back to the beginning. It's not about the practitioner's agenda. It's not about your agenda. It's about the client and understanding their world and how they think and what resources they've got, and just eliciting their skills, their strengths, and just trying to encourage them to make that change and the way that they want to do it, because you may think it's a completely wrong way of achieving what they want to do, but it's the way that they're going to try. And I'm sure everyone's heard trying is the first attempt, failure is the first attempt in what is it? Learning.
First attempt in learning.
There you go.
Yeah.
Failed at that.
But it ties in nicely with the whole concept of telehealth and people talking at the moment about, you know, should we be charging for giving advice? And, you know, this is all stuff that we kind of already do. And, you know, I think so many of us are so good at these soft skills already that we've almost, our patients almost take it for granted as part of the relationship. And now we're in a situation where we're having to emphasize, I'm doing it today, and emphasize that aspect. I haven't even been drinking, having to emphasize that part of it. Sorry. We're having to emphasize something that we naturally do that is taken for granted as part of the patient experience, and say, well, actually, you know, this is all stuff that's really important in getting you better as well, but we're now not going to touch you, we're just going to do this stuff as well. And so, you know, sometimes stressing these points, developing these skills can make us feel more confident. And as Awine said last night in the webinar, it can help us get out of our own way, because we can recognise that actually we have these many healthcare competencies that extend far beyond just how good an adjuster we are, or, you know, sticking needles in people. These are the things that actually help to get people better, because, you know, that this is the bit that facilitates a change in their understanding, a change in their interpretation of what's happening to them. And it's this, in my opinion, it's this that leads to long-term change and long-term improvements for our patients, much more than, you know, popping in and having an adjustment every 3 to 4 months, as the research says.
We're creatures of habit, and that's what we're trying to help our patients change, is their habits, their bad ones into better ones or healthier ones. So that's what this tool is all about, really.
Yeah. I'm just reminded of the quote. I mentioned this to a friend the other day. Said, you know, in a relationship, you can either be right or you can be happy, but you can't be both. And I think there's an element of that true for patients. Like, you can be right and you can be the one to have the answers, and you can go, well, here's my opinion. If you don't like it, you don't like it, and they can leave and not come back, and you can sit there feeling good that you stuck to your guns and you gave them the advice, but it didn't work. You didn't help, and potentially they're going to go and see somebody else, and who knows what advice they're going to get there.
Counteract that, actually, because you may have helped, because you may have pushed them into seeing someone else that may have, or you don't know, because you.
That's true. Yeah, actually, that's a good point.
But they may have gone home and thought about it, because that's a lot about what coaching is that you spend a lot of time with them in the process, but a lot of the work is done outside of coaching. And I'm sure a lot of the work, I mean, you've got exercises and all sorts of things, so a lot of the work for your patients is done outside of clinic as well.
Yeah, but I agree with you in terms of being right doesn't actually achieve anything. You know, we can sit there being smart about rightness, but that patient is probably not going to come back. So
I think if it's done for the purpose of you being right versus you helping, because and this is where I struggle, some patients do need tough love. Some will benefit from you saying, look, you just got to do your exercise or it's not going to get better.
Some need sacking.
That is important to use for some of them, and I'm just not. And that's something I tend to struggle with is knowing when to do that for the patient versus because I've just got frustrated and fed up, and I just want to go, well, it is your fault because you haven't done stuff.
It depends so much on context, doesn't it? Because that's not coming from a place of, you know, as I was saying earlier about the dangerous aspect of having an ego in healthcare. It's not coming from a place of I have to be right because I'm the one with the knowledge. It's coming from a place of, you know, I have to give you a little bit of tough love. And again, you can check in with people and just say, you know, look, I feel like we might need to give you a little bit of tough love in this situation. You can check in with them before you do it. So What if a person's idea of help is something that is against research but would just leave? I know it's very specific. That's a really good question. I mean, I had one chap when I used to work in a clinic in Midhurst who told me that his neck felt better when he hung a scarf over the door and then dangled from it, which I thought was going to be a pretty permanent fix for his neck pain. But again, you can validate people, and you can say, I understand why, or I understand the reasons behind why you're doing that, and you know how you might. I can understand how you might think that that's going to be helpful. Would you mind if I told you a little bit about what we know about that? You know, that technique that doesn't have research or anything like that. And then you can share your information in a way that doesn't say,
you're an idiot.
What you're doing, there's no research for it, there's no evidence base, you really shouldn't be doing it. You can do it in such a way that is still sensitive, and you can still, you know, they refer to it as rolling with resistance, so you can still influence the way that they change, the way that they're thinking about things. You can influence their understanding of a topic, and you know, what they believe to be factual, you know, and what worked for Great Aunt Marge, but actually we don't do that anymore because, you know, medicine has moved on. And you can do it in such a way that is very, very sensitive, doesn't create any barriers in your relationship with the patient, but still you're doing your due diligence as a practitioner by saying, actually, you know, it's quite a dangerous thing to be doing, you know, hanging yourself off a door frame with a scarf.
I quite like the approach I picked up from one of the MI things I did was they talked of it as like an advice sandwich. They said, so, you know, you offer it, you say, would you like me to share some of this information on that? And then you offer it, and then you ask, what did you make of that? Or how does that sound to you? So it's sort of checking back in again, almost like reflecting, to get them to reflect back to you what they've heard. Because sometimes you'll have said this and gone, oh, it's a really good job explaining that. And they heard something totally different and actually got quite the wrong end of the stick there.
Yeah.
So it's having that sort of introduction and conclusion of it too.
Yeah.
Really nice.
Yeah, almost getting them to reflect back what you have said to them.
Yeah,
to check their understanding.
Yeah.
Yeah.
Well, I think we probably better let everybody go, because we've winded on for an extra half an hour. I know. So we will share the recording for this across Facebook, and we'll email it out to everybody. So please do keep an eye out. We'll send out CPD certificates. As I said, we've got 270, something like that. So bear with us, but we will send them out with links to everything, with the resources and stuff like that. Chris, I'm sure you've got webinars coming up that you've got planned. I know we do. Do you have anything that you want to say?
Yeah, so I haven't got a date confirmed yet, but I'm looking at doing something on goal setting, hopefully in a week or two. So we'll share that in the group as well, and we can pop that out there.
Yeah, fantastic. So we're working on some other bits and bobs that are probably going to be on sort of application of these skills, but also you know, we've had lots of requests for sort of small group coaching stuff, so we're going to look to put that in place so that we can actually rumble with everybody. You know, I love rumbling with everybody, and you know, kind of work more specifically with people on stuff that they might want to ask. But we will still keep doing these webinars as long as everybody finds them useful. So yeah, just stay tuned and look after yourselves. It's crazy time at the moment, but yeah, we're all here to help. You know, Rhiannon and myself are, Chris is, you know, there's lots of support out there, so yeah, just use the resources that you've got. So
thank you very much.
Cool.
Brilliant. Thanks everybody. Enjoyed that.
Leave the meeting.
Cool.
Thanks guys.
Bye-bye.
Bye.
Bye.